Hi, good afternoon, everybody. Good morning. This is Rob Whittle here at DIEAGC. I was going to say thank you for all signing on and logging on for the webinar this morning. It's given me great pleasure to introduce Jamie Debenham. I think if you were able to listen to our last healthcare webinar we did, Jamie presented then, so you will have met Jamie before. The purpose of today is after we had some feedback from the last presentation we did, and I would agree that health insurance in the US compared to the UK is a very complex subject. So what we're trying to do this week and next week is break it down into a few more components to try and help everybody understand how health insurance works and what maybe some of the acronyms are and some of the compliance issues today. And then the presentation next week will be more about looking at things to talk about with respect to when you're renewing your policies and things you should be aware of, and maybe things that we can offer employees as retention, but also understanding the costs and the downsides to maybe doing certain things. What I would encourage everybody to do today is, as we go through, if you have questions, please type them in and we will try and answer them at the end or during the presentation. And anything that we don't get to, then we will follow up with the individuals afterwards and make sure that all your questions are answered. With respect to Jamie and myself today, we are going to try as best as possible to do it more on a sort of an informal basis, sort of have a bit of a chat as we go through to try and make it more interactive. So without further ado, I'd like to introduce Jamie Debenham, and Jamie helps us with our health insurance as well, and is, I think as most of you know, is a Brit originally and has been in the States now for about, I think, the last 25-30 years. So without further ado, Jamie, let's crack on with the presentation today.
Good morning, Rob. Thank you very much. Very much appreciate the opportunity to talk to our UK colleagues about health insurance in the United States. If we start going down the presentation, health insurance in the USA has a number of components that contain many acronyms and terms. Insurance over here is well known for all its different acronyms and stuff like that. And to make an informed decision on what insurance to offer your employees, it is really very, very important that you have a thorough understanding of these, or at least trust an advisor who can provide an expert guidance to you. But even then, you do need to have a basic understanding of what these terms are and so on.
But I think when we talked about this before, Jamie, with the health insurance arena over here has changed drastically since the Affordable Care Act came in place, which is affectionately known as Obamacare.
Yes.
And in reality, I think what the general populace was meant to understand from this is it was going to simplify healthcare, but I think it's almost complicated it more. So the fact is now there is more to understand and more to be aware of than potentially was before.
Right. Yeah. Frankly, healthcare reform is a behemoth, and yeah, the intention was to simplify the process, but in fact, it has actually made it a lot more complicated. And just to be completely frank about it, from my perspective, it's made me a lot more busy because people are relying on us to sort of guide them through this process.
So I think at the end of the day, irrespective of with everybody on the call, whoever they're using for their health insurance, they should now, in a sense, utilize their health insurance person a lot more to understand it because it's just so complex.
Yeah, they should be asking them a lot of questions. That there have been a lot of deadlines that have needed to be dealt with, and then those deadlines have been pushed off, and so you need someone who is kind of keeping up with what's going on with that respect. We've got a deadline coming up in December 31st of 2017 where the grandmothering options for businesses that have less than 50 employees is going to be going away, and everybody's going to be forced into the healthcare reform plans, the ACA plans. So today we will cover terms and acronyms in the following categories: the types of health plans that we have, the terms used in the plans, and then we'll cover some other industry codes as well. So just to get started, most plans in the United States have what's called a network, and the network is made up of hospitals and physicians and also facilities that are associated with medical care. So the first one is an HMO, Health Maintenance Organization. This plan is the most restricted network. It's usually centered around maybe 1 or 2 hospitals and a certain amount of physicians and other facilities that are very much associated with those hospitals. This plan, you generally have to have a primary care physician, and all your care is coordinated through that primary care physician. And then if you use physicians or hospitals that are outside of that network, then you would not have any coverage at all. So it's pretty restrictive. Generally, the benefits are fairly high, so the premiums are not necessarily any lower than any other type of network.
When you refer to the term of a primary care physician, from a UK perspective,
that would be a GP.
Your GP.
Yeah. Your local GP would be the one who would coordinate your care.
And really, with the HMO, if I understand this correctly, is if you needed to go and see a specialist, a bit like in the UK system, you'd have to go to your GP first.
Correct.
To get referred on to somebody else.
Yes. Yeah, that's correct.
So if in this situation, so say for example, you've got you as the company take out a HMO, and your employees, you believe, understand how it all works.
Right.
The fact is that to be covered under the insurance, they have to go to certain doctors within the network.
Right.
If they happen to be out of state or something like that, and they went to somebody else or not in their network, they just in effect would then just have to pay that out of their pocket.
Correct.
And I would imagine from a lot of...
Other than for emergency care is always covered. So if you're traveling out of state or out of your particular area and you have an emergency situation, then generally that situation is covered until you can be transported back to within your network.
Okay. But if within, so here, say we're in Ohio and we had a HMO plan and the employee went to somebody they shouldn't have done and they got a bill,
right.
Is that, I'm assuming that from an employer's perspective, because everybody on the line is an employer, or from that perspective is, then we don't have to worry about a liability issue, because obviously that's just the employee's made a bad decision.
It is important, but not legally required to communicate these plans to the employees so that they understand what the consequences are and what they can and cannot do. Communication is very, very important right now.
Mm-hmm.
Okay. So moving on, we get a little more liberal as we go down the line. The point of service plan is generally similar to an HMO, where you have a network, and if you're utilizing the network of doctors, you have to go to your GP and get referred out to a specialist. But then you may have some out-of-network benefits. So if you choose to go to a doctor that is not within the point-of-service network, then you would get some sort of benefit, and it would be fairly low compared with what you would get if you were within the network.
So once again, to clarify this, because I'm just trying to be conscious of the fact that we use a lot of terms over here that aren't normal in the UK. So if you use somebody within network, it's almost like, I suppose, you've got a list of preferred providers.
Correct.
Of, in effect, as long as you pick one of those doctors to go and see that's on the list you are provided with, they'd be deemed to be within the network, and you would be, under your plan, eligible for certain benefits and certain out-of-pocket expenses. You may have to do that. If you went to somebody who wasn't on that list, they become deemed to be out of network because they're not on the preferred providers list.
Right.
And if you go out of network, in effect, under the HMO,
you have no coverage.
You have no coverage. Under the point of service, and as we talk about much more, the PPO, you're going to have able to go to them, but it might cost you more, or the limits might be different, or what the insurance company reimburses you for would be different.
Right. Yeah. Exactly. And generally, we're kind of getting into the weeds a little bit here, but generally, if you go to an out-of-network doctor, the insurance company will reimburse up to a certain level, and it's usually called UCR, usual and customary and reasonable amount, and it's an average of what the providers are reimbursed in the area. They will reimburse the out-of-network doctor at that rate, but then if that doctor decides that they need more, they may come back to that employee and ask, and technically what we call it is balance bill them for the difference. So just a quick example, let's say UCR is $100, but the doctor wants $130, they could come back and ask for that additional $30 from, which would not be covered within the plan. Okay? So moving on to the PPO. PPO is probably the most liberal type of network that we have. This plan has preferred providers, that's hospitals and physicians. You can generally go directly to a specialist. So if you need to go to a cardiologist, you wouldn't need a referral from your GP. You could go directly to that cardiologist, or whether it's a knee surgeon or something like that. And then there's also an out-of-network benefit as well, again with lower benefits. So pretty simple. There is another type of plan where there is no network at all, and you can literally go anywhere, but they're usually, in this example, very, very expensive. As we get further and further into this, we can get into the weeds and talk about other options.
So with respect to what you see on a day-to-day basis with the different type of health plans, I'm assuming as we go down 1, 2, 3, the one you see the most of today in the marketplace is the preferred, the PPO.
Generally, the PPO is the one, I see most of all, especially for businesses that have employees in multiple states. I would certainly not recommend an HMO for a business that has employees in multiple states because it gets extremely complicated knitting those networks together, and you may have multiple carriers and it gets very, very complicated. So you want to try and do everything under one carrier if you possibly can, and so a PPO network makes it a lot easier because they're generally companies like United Healthcare, Anthem, Blue Cross Blue Shield, they have networks that go throughout the country and so on.
Okay, and just from a price perspective, the premium perspective, it doesn't seem as if there's a huge difference between 1, 2, and 3.
Not today. The benefits of an HMO might be higher than a PPO, but the premium would.
And when you talk about the benefits being higher,
so they might have a lower deductible, and a lower co-insurance than the employees, and we'll get into those terms as we go through.
Yeah.
So let's talk a little bit about the types of health plans that are available. Briefly, an individual health plan, that is a plan that is bought and paid for by an individual that covers themselves and their family. As of 2012, these are generally entirely covered by the Patient Protection Affordable Care Act, PPACA, PPACA. And so they're community rated, they're not medically underwritten. If you enroll during the open enrollment period, which is from October through January 15th, then there's no medical underwriting.
Okay. So you just mentioned there, we were maybe going to talk about it a bit later, but community rating.
Right.
So just briefly, in effect, what does community rating, because when you say it's normally underwritten, that would be, in effect, is the price you pay, and that is based on statistics, based on the risk, based on the claims,
right?
And that you would get. But community rating is different, isn't it?
Yes. Yeah, there are two types of rates. There's medically underwritten rates, and then there's community rates. Community rates is based on the zip code that you live in or postcode, and the age of the individuals and their smoking status. Okay, that's it. And the insurance companies have to develop a rate based on that. They submit that rate to the state Department of Insurance, and they get approved, and then they can sell those rates to the community.
And you and I were talking a little bit earlier today. For example, if we take Ohio, we were saying that because if you were in a zip code, a postcode that was within, I suppose, metropolitan Cleveland,
right,
you're mostly going to be paying a higher rate under the community ratings than maybe if you were in Ashtabula, which is more of a rural area to the east of Cleveland.
Correct.
Based on the fact that it's driven by the facilities, one of the factors is the medical facilities and the cost of that medical facility within that area.
Right.
And as we know, in Cleveland, we've got a lot of very good hospitals, and that obviously costs a lot more to run than maybe somewhere in a rural part.
Right.
Okay.
Yes, absolutely. So.
The other thing that might be interesting is talking about, we talked about an individual health plan here, is my understanding is that if you've only got, so if we've got a startup business in the US,
right.
and they've only got one employee over here, but they're a good employer and they want to try and give the employee health coverage, what you can't get, very rarely could you, or can you ever get group health insurance for one employee?
You can, but it's pretty rare.
Okay.
Yeah, I believe in Cleveland through the COSI, the Chamber of Commerce, the Greater Cleveland Chamber of Commerce, you can get a plan for one, but generally no. You need at least two employees.
So in this situation, this would be a situation where maybe an individual health plan would come into play if you wanted to help them. And the way you most really want to help them is say, look, you go and find the plan you want, discuss it with me, we agree that it's okay, but now we have to be careful how we reimburse them. So in effect is if their premium is $500 a month, whereas I think about 12 months ago, you could have written them a check for $500 to reimburse them. You can't really do that now. So if you're going to reimburse them, you'd have to give them additional wages.
Right.
And most probably have to gross it up for taxes so that the net ended up at 500.
Right.
So they could reimburse themselves. So it becomes more costly.
It does. It becomes more costly, but also technically you can't, by raising their salary, you can't mandate that they use that money for insurance. So they could go and use it for, going out to the Formulary house and having dinner.
Yeah.
So you don't have a lot of control on how the employee chooses to spend that money.
But that's the only mechanism now really that you could do to reimburse them.
Correct. Okay. Yeah, that's just on an individual.
On an individual, yeah.
So the second plan is a group health plan. That is generally, most businesses will offer this to their employees, and it's where the employees of a business are grouped together. And in the old traditional way, they were medically underwritten based on the group of employees. The employees would fill out a medical questionnaire and submit it to the insurance company. The insurance company would evaluate it and give them a rate. And that rate would be the same for each employee, depending on what category they take. So single, employee spouse, employee children, family coverage. Okay. Then, with the onset of PPACA, the Healthcare Reform Act, plans are now becoming community rated under the group plan for employers that have less than 50 employees. There are, again, getting into the weeds a little bit, there are a number of companies that are still what we describe as either grandfathered or grandmothered. And we could go on about this all day long, that are still medically underwritten, but there is a deadline coming up as of 12/31 of 2017 where that option is coming to an end unless you use a self-funded contract.
So for our particular situation, so our Diaxis policy renews every year on November the 1st.
Right.
We were talking about this earlier. Basically, we have been grandmothered under what I call the old insurance plan.
Right.
And we are still able to use that from this November the 1st until
through to December 31st of 2017.
But then after then, our rates are going to be determined based on the community rates as opposed to on our experience rates and our own internal demographics.
Right. And based on your situation, that could be a fairly significant increase in premiums. So we will need to discuss options there.
And just out of interest, is obviously we're talking specifically about Ohio here and community ratings and the grandmother rules. I'm assuming those are standard across the 50 states.
Nationwide, yeah.
And then once you get into then in effect but then when you get into the community rates in the respective states, those would all be done locally sort of thing and submitted within the local state to get approval.
Correct. Yeah. There are a number of plans that that are available to employees or individuals that are over the age of 65. And they come under Medicare. Medicare is a government-funded health plan provided to everybody who turns 65. Premiums are heavily subsidized and paid through Social Security benefits. So when you start receiving your Social Security, which is it's like the government retirement plan over here, they will withhold a certain amount of that to pay for your Medicare plan. You can purchase what's called a Medicare supplement, which would cover the gaps of coverage that Medicare does not cover. Medicare will cover, will have certain deductibles that you have to apply or cover. The supplement will cover those, and you pay an additional premium for those. It's generally less than what you would pay for your group health plan. And then Medicare Part D, that is the prescription drug coverage that will cover the prescription drugs that a retiree might be using. These plans are generally individual plans. You cannot force someone into a Medicare plan. If you have a group plan and you have employees who are still actively employed under your plan or in your business that are over 65, you can offer them this option, but you cannot force them into it. Generally, this option is going to be way more attractive than what you're offering as a group plan, because it's, especially if you get the supplement, you're going to pretty much have 100% coverage, and the premium is going to be lower. But we can talk more about how to do that as we go through that.
So the other thing, in effect, we're talking about the premiums, and we talked about before, obviously, depending on the size of the company, and some employers will pay 100% of the benefit, some will pay 25, whatever, and the employee makes up the rest with after-tax money.
Right.
The biggest difference, I think, between private healthcare in the US compared in the UK is when you provide private healthcare in the UK, it becomes a taxable benefit to the employees, so it actually costs them the tax. Whereas in the US, if the employer decides to give them health care and pay for it all, it's actually a tax-free benefit.
It is, yeah. But if there's any premium sharing, there is the opportunity for an employee to pay for their share of the premium on a pre-tax basis as well.
Yeah.
So there's a lot of tax benefits to offering private health insurance here. Medicaid, these are plans that are provided for individuals that are below a certain income level, generally the indigent, or less than a certain percentage of the poverty level. Okay. So moving into the healthcare reform, or PPACA, Patient Protection Affordable Care Act. They have a number of different types of plans that they offer, and the insurance companies have to comply with these categories, and they're broken up by metal, for the most part by metal color. So the first one is the Platinum plan, and Platinum has the highest level of benefits and the highest premium. Right now they're very rare and very often not part of an insurer's portfolio of products. They have a very low deductible, and they might even have 100% coverage once the deductible is met, but very, very expensive as well. All these plans that I'm talking about now, these are all community rated plans. These are not medically underwritten plans. So these are based on zip code, age of the employee, and their smoking status. The Gold plan will generally have a smaller deductible and a low out-of-pocket for the employee, but the premiums are generally pretty high. The Silver plan, plans will progressively get higher deductibles as you go down through the colors. The Silver plan has higher deductibles, more out-of-pocket costs in return for a lower premium. These are probably the most common offered right now. These also could include some consumer high deductible, qualified high deductible health plans, and I'll get into that in a little bit. And then the fourth one is a bronze plan. That probably has the highest deductible and highest out-of-pocket for the employee, but the premiums are the lowest. Generally, you want to weigh up, do you want to pay the lowest amount of premium, or do you want to have the highest amount of coverage? And that's really going to come down to what kind of health conditions you have within your family or within the group.
But with these different plans just to clarify, it's the employer that makes the decision what plan they are. So if they decide to go...
If it's a group plan, because these are also categorized like this under individual plans as well.
Okay, so you could have individual plans like this, but working on the basis that if an employer can take a group plan, they will do, because they want to try and give the benefit to the employees.
Right.
If the company makes the decision it's a gold plan, then it's gold for everybody, isn't it?
Yes, you can offer multiple plans.
Okay.
You can offer multiple plans, generally up to maybe 2 or 3 plans. So if you have 10 employees, you could offer a gold, silver, and bronze plan. And then it comes down to strategizing how you set up the employee contribution towards those plans to, allow them to go make a decision on which plan they want to go to.
Okay. And I'm sure there isn't an average, but if you were I think you said hardly anybody does platinum because it's just there. It looks nice, but it's not practical most probably from a costing perspective.
Well, and the insurance companies don't want to offer them either because they're just cost prohibitive.
So then we get to the gold, silver, and bronze. And we're talking about as you go from gold down to silver down to bronze, you've got the higher deductibles. So what we mean by that is that in effect the amount that the employee has to pay out of pocket before the insurance cuts in goes up. So what on average, so from a gold plan, what's maybe a typical deductible for a gold plan compared to a bronze? How much do they sort of alter by?
Okay, so a gold plan will have anything from about a $250 deductible up to probably $1,500 deductible. A bronze plan is going to have anything from about a $4,000 deductible up to the maximum, which is in 2017 will be $7,150.
Okay.
7,150.
So basically what that means to the employee then is from a cash flow, the employer is, first of all, you've got to pay your insurance, right, which you have to pay whatever, and however that's split. So if it's a 50-50 split, the employer is paid for that. But then before the insurance cuts in, he's going to have to, if he's on the bronze, he's going to have to pay at least a minimum of $4,000 out of pocket before he actually gets any benefit from the insurance coverage.
Right. Exactly. With an asterisk on that.
Yeah. But conceptually,
yes,
that's how it's working. Yeah.
The last category here is the catastrophic plan, and this is only available to individuals that are under the age of 30. So it's generally individuals who still think they're immortal and don't need anything, or anyone with a hardship exemption. Now, I have to question the whole reasoning behind the hardship exemption, because if you're having a hard time paying for the premium, you're not going to pay for a high deductible. So, but those plans are very high deductibles, and they generally will only have about a 50% co-insurance, so they'll be responsible for that as well. So as we move along, we're now going to get into, if you're looking at a plan summary, that is a summary of benefits. These are some of the terms that you're going to encounter while you're looking through that summary of benefits and coverage. First of all, the first one is the premium. That is the amount paid to the insurance company in return for coverage. The second one is the deductible. That is the amount that the member pays for covered healthcare services before the insurance plan begins to pay. So in order to satisfy the deductible, the service has to be actually covered under the insurance. So, but you're just paying that first part per the coverage.
So if we went back to a HMO plan,
right,
and I go to see the doctor and my deductible is $2,500,
right,
and I go to my doctor within network and I've got to spend at least $2,500 with him before I get any insurance coverage.
correct.
If I decide that I don't like that doctor and I want to go to somebody else, whatever I spend there doesn't even count to anything to my deductible because
Correct.
it's outside the network.
That's correct. Also, it might be an uncovered service. Very often in US plans, cosmetic surgery is not covered. So if someone gets plastic surgery or something like that, that is not going to be a covered benefit, so they may spend $2,000 on that. That it will not go towards your deductible. Okay. Co-insurance, that is a percentage that a member is required to pay, 20% for example, after the deductible is met. So it's an additional amount that the employee would pay. So you meet your deductible, let's say the deductible is $1,000, and then you might have a co-insurance, which is 80% that the insurance company will pay, 20% that the employee will pay, and you may have that for the next $1,000, $2,000, and they'll pay 20% until they reach that amount. Okay. And moving over, you then have co-pays. Co-pays, these are the amount paid by the member for a doctor visit or for prescription drug costs. Example, there might be a $25 office copay. There may be a $10 generic prescription drug copay or a $25 brand copay. These generally are not subject to a deductible. So again, so for an example, if you had your PPO plan and it has a $2,000 deductible, but it also has a $25 office copay, you would not be subject to that $2,000. You would just, if you go for your office copay, you'd pay the $25 copay and you'd be done. Okay.
But does that $25 that you pay for the copay actually now become part of that deductible you pay, or is that separate and distinct? So if your normal deductible for going to the hospital is $2,500,
right,
but I go to see the doctor because I've got a cold, and I have to, when I get to the doctor before I see me, I have to write $25. Have I used $25 of my $2,500, or is it mutually exclusive? And I've still got to use $2,500 for other medical expenses to actually get coverage by my insurance?
In the old days, yes, that would be correct. Under the Healthcare Reform Act, whether the plan is covered under the ACA or it's a self-funded plan, they have to comply with certain parts of the ACA. And so the $25 copay would actually accumulate towards the deductible, and the next category I'm going to talk about, the maximum out of pocket as well.
Okay. Just while we're talking about this in copay and we're talking about prescription, doctor's visits, prescription drug costs here is, so if I would normally take out, say, a silver plan, I'm assuming within that silver plan I take out my health coverage, but that doesn't necessarily cover prescriptions, does it?
For the most part it will, yes. There will be a different category of copays for the prescriptions, yes.
But are there other things when I take out, is there other things, so for example, obviously, you know, when you go to the UK and you're under the NHS system, that whatever you need medically, you don't really tend to think about it. Are there things that employers should be thinking about? Is dental normally covered under health? Is vision covered under health?
No. Dental, unless it's, again, this is where it gets kind of a grey area, but generally dental coverage is not covered. Your routine exams, your fillings, your crowns, your bridges, those kind of things are not covered under your medical plan. That comes under a separate policy. Same with vision. Those coverages, your refraction, the cost of the glasses and the frames and so on, those are not covered under your medical plan. It's a separate policy. Where it gets a little grey is if you have impacted wisdom teeth. That becomes a medical procedure, and that would be covered under your medical plan generally. And again, if you have cataract surgery or something like that, that would be covered under your medical plan.
So in reality, it's just making people aware of that, in a sense, when you take out health insurance, you need to make sure whether you want sort of vision covered as well, and whether you want to offer dental as well, because they're not going to be by default covered under your health insurance.
Correct. Yeah. Okay, so maximum out of pocket. This is the maximum amount of dollars that a member or a family will pay out of pocket for medical services in any one calendar year. This includes the deductible, it includes the office copays, prescription drug copays, etc. Once those numbers add up to what the policy's maximum out of pocket is, then you are done, and the insurance company pays 100% of the any other claims that you might have. The maximum out of pocket for any plan, as mandated by the government, is $7,150 for an individual, $14,300 for a family, and that's in 2017. Now, your plan doesn't necessarily have to go that high, but those are the maximums that you can go to.
Okay. I think the interesting thing here, and it's just just a very small technicality, as you put here, is this maximum out of pocket is calculated on a calendar year basis.
Yes.
Whereas your plan might actually not be on a calendar year basis.
That's right.
So you could be in a situation where you could have an employee that thinks within the plan year they've reached these limits, but because of how the payments have fallen, then they might not have reached them.
We're going to cover that on the next page. Yeah, so your plan is built up either on a plan year or on a calendar year. So the calendar year, your deductible, your co-insurance, your maximum out of pocket generally run on a calendar year basis. So they go from January 1st through December 31st of any calendar year. The plan year, that is the premiums that you pay for the insurance, will generally run from, it can run from January 1st to December 31st, but your plan actually may start on April 1st and go through March 31st of the following year. And so those two will very frequently not coordinate. And you need to pay attention to this when you renew your plan, especially if you're making a change in insurance company and or a change in the amount of deductible that you have. The reason why you need to pay attention to this, because if you make a change, say on April 1st, your employees are entitled to a credit of the amount of deductible that they've used up from January 1st through April 1st. Most insurance companies will not require you to restart your deductible if you make a change. Okay? If you increase your deductible but stay with the same insurance company, then you will get credit for the amount of deductible that you've already used, but then you'll be liable for the additional deductible that you've taken on.
And really, the coordination of all this, it's it's done behind the scenes by whoever within the insurance company or whatever.
Yeah, and people like myself and the insurance companies will coordinate that and make sure that the employees get their credits.
And normally what happens here is, when I know with my insurance, is when I do go to the doctors and that, I normally get a statement that comes back to me showing how much I've spent out of pocket to date within network and out of network, and what I've still got left to go.
Yeah. Okay, some additional terms found. You may see the term ER, that is the emergency room. There may be a separate copay for an emergency room, and it will be significantly higher than your office copay. It's usually around $250 or around up to $500 for that. Urgent care, that is, there's a number of urgent care facilities around the town here, and there are around the country. They're less expensive than emergency room. So, you've got a flu situation or something like that, then you would utilize the urgent care. They usually run about a $50 copay or something like that. Inpatient, that is clearly a procedure that involves an overnight stay in the hospital. Outpatient is a procedure that is done outside the hospital setting or does not involve an overnight hospital stay.
Just out of interest, so with the urgent care, because obviously I think most insurance companies and most people would say, if you're not feeling well, you go urgent care first, and then the urgent care might send you to ER.
Right.
With the different co-pays, you may want to know the answer is, so if my co-pay for urgent care is $50,
Right.
and I go to urgent care and they say, in actual fact, we can't deal with you here, you need to go to the ER, and the ER is $250, do you now end up having to pay $300, or do you get a credit for the $50 you've already paid at urgent care against your ER?
That's a good question, and it will depend on whether the urgent care is associated with the hospital system that has the emergency room. So, and generally they are. So some miscellaneous options or acronyms that we have. HSA, that is a health savings account. That is a qualified bank account utilized by members to put aside money to pay for qualified medical expenses. There's the IRS has a list of qualified expenses that they can use this for. An HSA or health savings account has to be accompanied by a QHD-HB, qualified high deductible health plan, and can be funded by both the employer and employee up to annual maximums. These have become very, very popular because it allows employers to offer a higher deductible health plan, but then subsidize the employee with money in their HSA account.
I think the policy behind this is to get the employee sort of to realize they're responsible for funding some of their health care as well. And from a tax perspective, when you put into the HSA, it becomes a deductible against your income, so you get tax relief on it going in.
Yeah.
And to the extent that you don't utilize it when you reach 65, it in effect becomes a pension plan for you.
Right.
And you can then draw down it at a later date. So I must admit, I personally have looked at this because of our pension that I since put into an IRA, which is a pension. I'm also putting into a HSA with the intention that I'm not going to draw it all down, and in effect it becomes a quasi pension plan for me as well.
Yes. Yeah.
I think the other thing that's interesting with the HSAs is just the fact that they are, originally I think people weren't that familiar with them now, but it's almost become second nature now that I think almost everybody is expecting when they take out a health insurance plan that there will be a HSA with it. That's what I'm tending to see now. Yeah,
HSAs have been around since 2003, so they were brought into play by the Bush administration. And right now they make up probably more than 50% of the health plans out there. You know, they've grown very, very rapidly, and they continue to do so.
And once again, in effect, when we've been talking about the deductible, so in effect, so if your deductible is, I'm just using easy maths here, 5,000, and you happen to be in the tax bracket of 40%,
right?
In effect is by taking the money out of the HSA, you're in effect is actually costing you only 60% of the original cost.
Right.
So that's another reason, in a sense, is if you are with these deductible plans, it's basically saying ultimately if you do this correct, you would end up paying with after-tax money for your medical expenses, which is far better than the normal tax rules of deducting medical expenses on your tax return.
Mm-hmm. Yes, absolutely. Yeah, yeah. Because when you deduct it, you know, I'm not an accountant, but when you deduct it directly from your taxes, you have to have incurred a certain threshold of medical expenses to even get any benefit out of it.
Correct. Yeah.
Where here you get an immediate benefit.
Yeah, immediate benefit. Yeah.
The HRA, it's a health reimbursement arrangement. This is a qualified reimbursement arrangement whereby an employer agrees to reimburse certain medical expenses on behalf of the employee up to a predetermined amount. The arrangement must be entirely funded by the employer. Again, you would utilize this type of plan or this mechanism with a high deductible plan, and you would just reimburse the employee for medical expenses incurred up to a predetermined amount. And why would you use an HRA versus an HSA? If you're funding an HSA as an employer, once that money goes into the employee's account, it is their money and there's no recourse to get it back. Whereas with an HRA, if you only fund what's actually incurred, and you keep whatever whatever is not incurred. Okay, so it might be more attractive for an employer to use the HRA. Okay.
So I was going to say thank you very much for that, Jamie. I know we've got some questions. If on our panel here, it doesn't appear there's any questions, but if for some reason somebody has asked a question and obviously it's just not appearing on our system, please email it to me afterwards, and I will get an answer for you. But I've just got a couple of questions here for you, Jamie, just to sort of follow up on what we've been talking about. Is we've been talking about the acronyms and more of the mechanics of plans today.
Right.
The one thing that I don't think we have touched on at the moment is compliance issues with plans.
Right.
So obviously I go, actually we go through you sort our plan out, you put it all in place. But what responsibilities as the employer of various compliance issues do I need to be aware of and take care of as a small employer to make sure that I'm not falling afoul of anything and putting the company at risk?
Well, under the Healthcare Reform Act, an employer that has less than 50 employees, you are actually not obligated to offer anything. But your employees are obligated to purchase health insurance. So, people who are have less than 50 employees will very often still continue to offer a group health plan purely from a retention point of view, also from a just as a good benefit for the employees. If you are choosing to offer a health plan and you have a contribution for your health plan, so the employees are contributing, you need to make sure that each employee either signs up for the plan or signs what we call a waiver, which is an acknowledgement that they've been offered the plan and they are choosing to decline the plan. It is very, very important that you get that, because when that employee that has chosen to decline the plan and has not bought a plan through either the exchange or in the individual marketplace, and they get a fine through their taxes the following year, they may well come back to you and say, you never offered me a plan. This is proof that you have offered the plan. You need to keep those on file, and it's very, very important to do that.
So I think that's an interesting point you raised there about fines, just so that everybody's aware. In the US now, by law, whoever you are, you're supposed to have health insurance unless there's a few exceptions.
Right.
So if, for example, as an employer with less than 50 employees, you are not mandated that you've got to have insurance out there or even offer insurance to your employees. But if you don't, your employees then are required by law to go out and get their own personal insurance.
Right.
And if they don't, that's where you're talking about the fines that come up and you end up paying a fine on your tax return when you file it.
Right.
The fines when they first came in weren't that high.
Right,
so
they're getting higher.
They're getting higher, and I think what people would do practically, they'd go, okay, well, my health insurance is going to cost me $200 a month. My fine is $200 for the year.
Right.
I'm just going to pay the $200 for the year.
Right.
But those are going to narrow, so to encourage people to take health insurance.
Right.
We've got a few questions that have come in. First one is in effect of if in effect you start to go over 50 employees, how does, because we've really been talking about less than 50 employees today, what are the major changes in respect to what you have to offer for your staff if you go over 50? And it is, I think we talked about this before, this is only 50. So if you've got a UK company and a US company, this 50 employees is only looked at on the US employees.
It's only looked at from the US perspective.
Yes.
So they're not interested in what you have in the UK. They are interested in what you have in the US. And so if you have employees in multiple states, you may have 20 in Ohio, you may have another 30 in Pennsylvania and another 20 in North Carolina. You are essentially a company that has more than 50 employees. The other way they count it is based on common ownership. So if you have a partnership with another business and you have a certain percentage ownership of that business, they're going to count both of your companies to see where the number of employees are concerned. They're also going to count them based on what's called a full-time equivalent. So they'll take all your employees that are working 30 hours or more, and then they'll take all your employees that are working less than 30 hours, and they'll aggregate them to make what's called a full-time equivalent. And if your number comes over 50, then you are obligated under healthcare reform to offer a health plan to your employees. And that health plan has to be what's called minimum essential and affordable. Okay? Minimum essential means it complies with healthcare regulations as to what is covered within the plan. The deductible can't be over the $7,150 for an individual, and the maximum out of pocket can't be over that, et cetera, et cetera. The affordable part is you cannot charge more than 9.5% of an employee's household income for their health insurance. Okay, so if you're paying 100% of the coverage, that's all fine and dandy, because you're going to be well beyond the 9.5%, or well within the 9.5%. But if the employees are making a contribution, you need to make sure that it's not, and there are testing ways that we can figure that out.
But assuming that with all those the testing out, we're at 50. What are the major things that we need to be aware of that are the major differences between under 50 and over 50 employees?
Well, under 50 is community rated. Over 50 is for the time being is still medically underwritten. Okay, and there becomes more options as far as health plans are concerned. You're not constrained to the metal plans, the platinum, gold, silver, bronze plans.
So at the moment, once we've all gone out of the grandmother stage, if we're small employers, then in effect, being over 50, you get the ability to still have a plan that was like the traditional plan, where it's medically underwritten. I imagine the other thing is that once you get to 50, these full-time, you have to, as an employer, offer health insurance. It's not an option now.
Right. So you need to fill out there are some documents that you have to complete. The 1095 and 1094, and there's an A, B, C version of each one of those.
So once again, these are layman terms that are IRS forms that the employer or the health insurance company have to fill out in behalf of the employees and get sent out to them, so that they have that information, so they can personally know how to fill out their tax return correctly.
Right.
So I'd imagine, so those have to be done. From a compliance cost or compliance things you still have to do the waivers.
Yes.
Is there anything else from a...
No, a waiver is not mandatory, but it's really highly recommended.
Yeah. Okay.
Yeah.
And then from the other thing is, as you as the employer, you have to offer a health insurance. Mm-hmm. Then once again is you can't discriminate, or you basically got to offer it to everybody, so you can't pick and choose.
Everybody over 30 hours.
Over 30 hours, yeah. Okay.
That's 30 hours per week working.
Yeah. Okay. Yeah. So those are I suppose the major things. So in effect, is for any plan what we've talked about today, all these terms tie into either under 50 or over 50.
Right.
But the major change with over 50 is, in effect, is the type of plan that you can have, and also the fact that you have to offer health insurance.
Right. And frankly, if you've got more than 20 employees right now, ACA, if you're medically underwritten right now, and you're facing going to the ACA, you're going to see a fairly significant increase in premium. Mm-hmm. So you may want to be looking at some other alternatives. We're getting into the weeds a little bit here, but you may want to be looking at self-funded.
So these are mostly options we'll talk about next week in more detail.
Yeah.
Okay. And I think everybody who's on the call today is actually signed up for next week, so we'll get into those next week. Another talking about is so you take out insurance in the US, and obviously a lot of everybody who's on the call today mostly travels between different countries. I'm assuming it's insurance company or policy by policy is whether you are covered when you're overseas, either working or on holiday, by a US plan. Is it policy by policy, or is it general thing that if you have a policy in the US, that if you go to Canada or Mexico or the UK and something happens to you while you're out of the US, that you're still covered under your plan?
You're not covered for general, you're covered for emergency situations. you're not covered for, you can't do what we call medical tourism. So you can't decide that you're going to go and have a knee replacement in India or a hip replacement in India. That would not be covered unless it's actually written into your plan.
Okay.
So that it could go policy to policy on that.
And is it my understanding that normally if you're overseas and you are taken ill, that it's good, if you can, it's good policy to call up the insurance company and
Yes.
sort of get clearance before you have anything done?
Generally, if you're overseas, you will be covered for emergency situations. You will generally be asked to pay the bill in the local currency, but you'll need to get the emergency room or the hospital or wherever you are to generate an invoice in US dollars.
Okay. Okay. And I think then the final question we've got at the moment is talking about, it's actually a tax question more from, so with the HRA contributions, I'll have to double check this, but I'm pretty sure that the HRA would not be a P11D benefit because it's something being provided by the employer that's written into a plan. But I will double check that and get back. But as I say, I think I want to make sure that we finish on time. I haven't got any more questions at the moment. Thank you very much, Jamie, for spending this hour with us, and hopefully everybody on the line picked up something or got something of value from it. And like I said, I think everybody's going to join us next week where we're going to get into more of the nitty-gritty of things to look at when you're renewing your policy and things to ask and things to understand about the actual premiums. And so I was going to say, if anybody has any further questions, then please feel free to email me directly. I know everybody's got my email. But thank you everybody for attending this morning. Hopefully everybody found it useful, and we will look forward to seeing you next week. Okay, thanks very much. Bye-bye.